Good morning, respected teachers, doctors, seniors, my colleagues, and dear juniors. I'm Sonia Kunwar, and I'm from BPKMCH Nursing College, BNS Oncology, third year, fourth batch student. And today I'm about to present on topic post-operative care of patient after thoracic surgery from nursing perspective. So, what is thoracic surgery? It's a surgical procedure involving organs in the thoracic cavity, lungs, esophagus, chest wall, and mediastinum, often used to treat trauma, cancers, infections, congenital issues, and performed by open thoracotomy or minimally invasive techniques like VATS or robotic surgery. There's a list of thoracic surgeries, and most commonly, most of them are often performed in our setting. Related to lungs, there's lobectomy, pneumonectomy, segmentectomy, wedge resection, sleeve resection, bullectomy, long volume resection surgery, extrapulmonary pneumonectomy. Related to pleura, pleurectomy, pleurodesis, decortication, which is the removal of the fibrous layer in the pleura, thoracocentesis. Related to mediastinum, there is thymectomy, which is the removal of thymus gland, mediastinoscopy, mediastinal tumor resection, pericardiectomy. Related to chest wall resection, reconstruction, rib resection, sternotomy, diaphragmatic plication, which is often done for diaphragmatic paralysis. Related to airway, there is tracheal resection and reconstruction, bronchoplasty, sleeve resection. Related to esophagus, esophagectomy, esophageal myotomy, esophageal perforation repair and fundoplication. Related to trachea, tracheal resection and reconstruction, tracheostomy, airway stenting, and finally minimally invasive thoracic surgery like VATS and robotic assisted thoracic surgery, which is yet to be performed in our setting. So heading up with our topic, what is post-operative care? So it's the care provided to patient after ongoing surgical procedure, often focuses on pain management, infection prevention, wound care, early mobilization, and complication monitoring, whose further aim is to support recovery and prevent post-surgical complications. So before talking about the topic, post-operative period, when the patient undergoes surgery, right after it, when the patient is transferred to recovery, post-operative or ICU, until the patient is transferred to ward and till the follow-up. But in today's presentation, I'm going to focus and highlight the period when the patient shifts from post-operative and ICU to the ward until the patient is discharged. So we're on our main topic, nursing management of patient after thoracic surgery. In any care we provide, the furthermost and main phase of nursing management is nursing assessment, in which ABCDEFG assessment framework is often used, which is a systematic approach to assess and manage critically ill or post-operative patient. So it's most commonly used to prioritize life-threatening condition and ensuring prompt intervention, but it can also be used it is highly effective in the post-thoracic surgery patient to monitor recovery and prevent complications. And about this ABCDEFG nursing assessment framework, right in our ward, when the patient shifts from post-operative or ICU to the ward, we do observe and assess the patient generally. All of these things we do assess, but we don't exactly use the ABCDEFG nursing assessment framework in our setting. So it's high time when nurses use this assessment framework to assess the patient. About nursing intervention, the first is respiratory care, under which oxygen therapy. So we must maintain the SpO2 of the patient above 92% and administer oxygen as necessary, or if the symptoms of hypoxia like restlessness, dyspnea, tachycardia, and cyanosis. But before administering nursing oxygen therapy, we must be aware about the nursing oxygen delivery systems and what is their flow rate and how is it used. Like nasal cannula, it delivers up to 1 to 6 liter per minute flow rate with 24 to 44% of FiO2, and it's used for stable patients with mild hypoxia, while simple max administers 5 to 8 liter per minute of flow rate with 40 to 60% of FiO2 delivered. And it is used in moderate hypoxia, and we must the oxygen flow rate should be more than 5 liter per minute to prevent carbon dioxide buildup. And Venturi max, it varies by color, but flow rate 4 to 15 liter per minute is provided with 24 to 60% of FiO2. Non-rebreather mask provides 10 to 15 per liter per minute flow rate with 90 to 100% of FiO2, while high-flow nasal cannula provides up to 60% with 100% FiO2 delivered. Next up is airway clearance. So we must encourage effective coughing and deep breathing exercise every 1 to 2 hourly for patients, and encourage use of incentive spirometry hourly while awake to prevent atelectasis, and suctioning as needed in sterile technique, and humidify oxygen to prevent mucosal dryness. Another is positioning, elevating the head of the bed 30 to 45 degrees to ease breathing, and positioning patient on non-operative site or semi-forward position facilitates lung expansion and drainage. About this, we'll also discuss further in later slides. Next up in fourth is most important chest physiotherapy, which is a set of techniques used to mobilize and remove pulmonary secretion. And it is used to improve ventilation and oxygenation. It is used to prevent post-operative complications like atelectasis, pneumonia, and hypoxemia. So what are the techniques of chest physiotherapy? Percussion that involves rhythmic clapping on chest wall with cupped hand to loosen secretion, while vibration involves a gentle oscillatory pressure during exhalation to help move secretion centrally. Postural drainage involves using gravity to drain secretion from specific lung segments, while deep breathing and coughing exercise encourages lung expansion and ventilation to help expel loosened secretion effectively. Above the picture, it is of postural drainage. In first picture, the affected segment is lower lobe superior segment, where the patient is placed in prone position with pillows underneath the abdomen. In second picture, the patient is affected segment is upper lobe anterior segment, where patient is kept in Trelleborg position, whereas in third picture, the patient is kept in high position for apical segment upper lobe. While in the last picture, the affected segment is upper lobe posterior segment, and patient is kept in sitting position with slightly leaning forward. About the nurse's role in chest physiotherapy, coordinating with the physiotherapist to ensure proper timing and frequency, pre-medicating for the patient 30 minutes prior to the therapy, analgesic as prescribed, and monitoring patient response, watch for dyspnea, hypoxia, fatigue, and dizziness, assist in position with pillows, bed, or adjustment for comfort, assisting position, provide oxygen as needed, encourage hydration, educate the patient. And if the aspirator falls during the procedure, it should be stopped. And what are the contraindications of chest physiotherapy? So there is absolute and relative contraindication. Absolute, in which the chest physiotherapy should never be done, and relatively it can be done but with caution. In absolute contraindication, there's unstable hemodynamics, untreated or tension pneumothorax, active or massive hemoptysis, recent pulmonary embolism, severe bronchospasm or airway obstruction, open chest wound, fresh surgical site, raised ICP or uncontrolled ICP, recent myocardial infarction. While in relative contraindication, nausea, vomiting, or abdominal distension, mild to moderate hemodynamic instability, confusion or inability to cooperate, history of thoracic aneurysm, etc. About the fifth is chest drain care, in which assessment areas are patency, and nurses should check if there is no kink, loop, or clot in the tubing, and about drainage amount, measure hourly, and report if there is sudden drop or more than 100 ml per hour. Drainage character, either serous, sanguineous, or purulent. Air leak, bubbling in water still indicates air leak, and about swinging, fluctuating with breathing is a good sign, and insertion sign for redness, swelling, leakage, and odor. And about system position, it must be below the chest level, and we must not clamp the chest tube unless ordered. About the problems and nursing actions, if there is no drainage or no swinging, then check for blockage or dependent loops, reposition the patient. And if there is continuous bubbling, then it may indicate air leak. Check the connections and notify the physician. Drainage, if suddenly drops, then we should inspect for clots or kinks, assess respiratory distress, and if accidental connection occurs, then reconnect if sterile technique possible, otherwise place the end in sterile water. If the tube becomes dislodged, Then cover the insertion site with sterile or three-sided dressing and inform the doctor if needed. So the last one is incentive spirometry, which purpose is it is a respiratory therapy technique, and it promotes alveolar expansion, prevents atelectasis and hypostatic pneumonia. It improves oxygenation and ventilation and enhances lung function recovery after thoracic surgery. Instructions for proper use are that instruct the patient to sit upright or semi-forward position, hold the device upright and exhale fully, place the mouthpiece in mouth and seal lips around it while inhale slowly and deeply. Hold breathe for 3 to 5 seconds at full inspiration, exhale slowly and rest, and repeat 10 times per hour while awake. About nurses' responsibility, demonstrate proper technique. Nurses should first show the patient how it is done and assess the patient's readiness. Either they are awake, oriented, or in severe pain. Either they are pre-medicated if necessary or not. Motivate and monitor compliance. It encourage use at least every hour awake and record outcomes for document frequency of use, volume, lung sound improvement, and observe for complications like dizziness, fatigue, pain, or poor technique. So we just finished the respiratory care. Next up is pain management. Under pharmacological pain management, so paracetamol and NSAID like ibuprofen, diclofenac, ketorolac should be given if pain, and it is contraindicated in patients with kidney problem or bleeding problems. And opioids like morphine, tramadol, fentanyl is given either by injection or PCA. PCA is not that common in our setting. Regional technique like epidural, anesthesia, and nerve block can also be used. While in non-pharmacological positioning, semi-false position, breathing, and other breathing positioning techniques that aids the patient. Breathing exercise like use of spirometry, deep breathing and coughing exercise, relaxation techniques, etc. Cold and hot pack can be applied, and emotional support, early mobilization, encourage sitting and standing short walk if possible, and help reduce stiffness and pain. So the nurse's role in pain management is assessing the pain using our pain management pain assessment tool, and timely medication administration, monitoring for side effects, educating patient on breathing, movement, and how to use patient control anesthesia, which is not applicable in our setting. So next up is wound care and management. So the nurse's role in wound care is assessing the wound regularly, changing dressing as per hospital protocol or if soaked, contaminated, support with proper nutrition to promote healing, and educate the patient on wound care, hygiene, and when to seek help, and main documentation. There's a wound assessment checklist available which should be done and recorded every shift per hourly, every shift as protocol. The parameters are the size and shape, measure the length, width, and depth, wound edges for either they are approximated, gapping, or separated, drainage or exit, serous, serosanguinous, sanguinous, or purulent, color of wound bed, either it is pink, yellow, black, which indicates healthy, slough, and necrotic, sign of infection, redness, warm, pain, swelling, fall odor, and surrounding skin either is macerated, edema, etc. And pain level, local pain or tenderness during palpation or movement. Next up is infection prevention. We should be using standard precaution to prevent the infections and surgical site infections and all. Environmental control like cleaning bedside, disinfecting high touch areas, and main about the device care. IV cannula, it as per the CDC guideline, inspect the site every 8 hourly and every 72 to 96 hourly, which is 3 to 4 days. The routine replacement of the IV cannula should be done to prevent infection, and if sign of phlebitis infection malfunction, it should be changed sooner. Foley's catheter, perineal care should be done at least once daily and after bowel movement, and catheter care every shift wise should be done, and usually every 2 to 4 weeks it is done as per the hospital policy. About nutrition and hydration, fluid and electrolyte balance. It's nurses' furthermost role in IV fluid management and nutrition, maintaining prescribed IV fluid and monitoring overload, checking intake output, and either the urine output is more than 30 ml per hour or not. Monitoring for electrolyte imbalance and nutrition, assessing swallowing before oral intake to prevent aspiration, starting with clear diet as tolerated, and encouraging small frequent meals in high protein and calorie to promote healing. So next up is mobility and positioning. Importance of early mobility is that it prevents atelectasis, pneumonia, deep vein thrombosis, and improves lung ventilation perfusion, promotes circulation and wound healing, reduces muscle conditioning and pressure injuries. According to type of surgeries, the recommended position and its rationale, including lobectomy, semi-followers or high-followers position, the patient is educated to lie on non-operative side as it promotes expansion of remaining lung and prevents mediastinal shift, whereas pneumonectomy patient is said to lie on operative side, semi-followers position. It allows the fluid to fill empty space and prevent mediastinal shift or tension. Thoracotomy, semi-false position, avoid lying flat and reduces pressure on lung and promote drainage and breathing, while VATS, usually semi-false position. Position depends on size and position, and it is minimally invasive surgery, helps in positioning and support. About ambulation, day one onwards, ambulation is done with assistant 2 to 3 times per day. We nurses must encourage the patient for early ambulation and must ensure that pain is first well managed before the mobilization and encourage frequently sitting in a chair. Complication assessment and prevention. So the complication like the signs of atelectasis, which are reduced SpO2, reduced breath sounds, and preventing it is by incentive spirometry ambulation. Pneumonia, sign of fever, crackles, cough, preventing by oral care, early mobility, and pneumothorax. Shortness of breath, tracheal shift, monitoring chest drain and securing the connections, while hemothorax, reduce blood pressure, increase heart rate, bloody drain, and preventing it by monitoring drainage outly and report bleeding. Subcutaneous emphysema is crepitus and swelling are the common signs, and monitor and notify surgeon. And about DVT and pulmonary edema, lymph swelling, shortness of breath, early mobility, and DVT stockings can be provided to the patient and hydrating. About the discharge teaching, when the client or patient is about to discharge, then about the wound care, pain management, breathing exercise, activity, nutrition and hydration, and follow-up care, the patient is to be provided discharge teaching. And sorry, when you seek help, call healthcare provider if the fever above 100 Fahrenheit and shortness of breath, chest pain if not relieved by medication, excessive or foul smelling, wound drainage, and signs of infection or swelling. We must educate the patient during the time of discharge. So, summary on why post-operative care is essential. The benefits of post-operative care, it includes early complication detection. It prevents emergencies and ICU transfer. Breathing and airway support, it reduces the respiratory complications, while pain control enables mobility and lung expansion. Infection prevention avoids sepsis and delayed healing, while patient education and support reduces anxiety and empowers recovery. Coordination of care enhances holistic recovery, while early mobilization improves circulation and lung function. And above nutritional support speeds up healing, and discharge planning ensures safe home care. And the main thing about this is that a shorter hospital stay and fewer readmission that impacts on better recovery and lower healthcare costs. About the conclusion recommendation. In 2022, a meta-analysis was done, examined the impact of quality nursing care on surgical site infection in patients undergoing thoracic and cardiac surgery in China. The study included data from over 3,000 patients and found that those who received structured high-quality nursing care had significant lower risk of developing surgical site infections compared to those who received routine care. So, specifically, the odds of infection were reduced by 64%, and the finding also highlighted the critical role of nursing in preventing complications and promoting better recovery outcomes after thoracic surgery. Another research was done was a cross-sectional study done by 9 et al. in BMC Pulmonary Medicine in 7 tertiary hospitals in Beijing found that thoracic nurses had positive attitude and good practice toward post-operative pulmonary rehabilitation through their knowledge, though their knowledge was moderate. Factors like gender, age, education, hospital level, and experience influenced their knowledge, which in turn affected the attitudes and practice. So this study recommended targeted training to improve knowledge and enhance patient recovery. So these are the references. Thank you so much.